Good afternoon, everybody. Delighted to be here to chair this session today. So this session is going to focus on how our modern lifestyle has transformed movement and health. And I'm really delighted to be joined by three fantastic kind of researchers who are going to take you on a bit of a journey, kind of starting with the history to the current day and then to the future. And that will be Jason at the end. And we do know that it's between us and lunch, so we will try and keep to time. Jason. Okay. First of all, I'm delighted to hand over to Professor Adrianne Hardman, Emeritus Professor in the school, who's going to talk a bit about the history of our movement and health. Thank you.
Thank you very much, Stacy. Good morning, everybody. I'm very much outside my comfort zone because whereas this used to be my bread and butter, it clearly hasn't been for a long time. In fact, last week I had to cope with a Teams meeting. And that was definitely a shock to the system, but we got through it. I don't think I had any picture. Anyway, by and by. And of course, we've got to follow that wonderful last 3/4 of an hour of historical discussion. So after this Teams meeting, it became clear that my brief, excuse me, forget my glasses, but my brief is really to summarise some of the early research in exercise and health. And then I'm going to go on to talk a little bit about some of the early studies in this sort of area at Loughborough. So modern day research in exercise health really started after the Second World War, of course, when public health was changing. It was changing to focus on non-communicable diseases and the modification of individual behaviour, rather than in the past on mainly infectious. Am I doing something?
You can just stand there and that's fine.
That's going to work, is it?
Yeah, that's fine.
Okay. So then while Dole and Hill worked on the links between smoking and lung disease, Professor Jerry Morris from the London School of Hygiene and Tropical Medicine set out to test the hypothesis that deaths from coronary heart disease were less common in men who were engaged in physically active jobs than in those in sedentary jobs. So in 1953, they published seminal papers. I got my first slide. How do I get that? I'm more used to having lots of data slides to rely on and interpret, but I've only got two today, and one is a bus. In 53, then, Jerry Morris and his group published data showing that conductors on the London double-decker buses who climbed something like 600 steps a day up and down the stairs, they had less than half the incidence of coronary heart disease as the drivers who sat for probably 90% of the time on their shift. An obvious confounding factor, of course, is body mass, because if you're a big man, which job you apply for? You apply to sit in the cab, don't you? So this Jerry addressed in a wonderfully simple way. He asked the London transport people to give him the waist size of the uniform trousers, and then controlled statistically for that very crude measure of, I suppose these days, what we call central obesity. But the protective effect of the occupational exercise persisted. So in the years that followed, other occupational groups were followed in the same sort of way. So San Francisco dock workers had a lower incidence of heart disease than their sedentary peers, and in the UK, postal workers who walked and cycled to deliver the mail, they also had a lower incidence of heart disease. But by the time we moved on to the 60s, heavy manual work was really definitely not on the agenda. And so the emphasis shifted, and then leisure time physical activity became the major component of total physical activity. And Jerry Morris and his good friend Ralph Paffenbarger in America used questionnaire data instead to get some information about the exercise habits of respectively a big cohort of English civil servants, and in Paffenbarger's case, Harvard alumni. So they used the well-established network in American universities of keeping in touch with the alumni. And consistent, those two types of studies, because there were a series really, they consistently showed that both total energy expended in physical activity and participation in strenuous sports were associated with a lower risk of heart disease. In the case of the Harvard alumni, it was clear that only physical activity in later life contributed to this protection. And it was clear that men who'd been university athletes as students but became inactive in later life, they didn't have any sort of protection. So there was an early signal that the exercise had to be current. Complementary studies, mainly by, notably by Steve Blair in Dallas, sought to get round the problems with questionnaire data by measuring instead the characteristics of the people who were habitually active. In other words, they measured fitness. Of course, that's also got its problems, like most approaches, because cardiorespiratory fitness isn't just a function of habitual exercise. You know, it's influenced by environmental factors and genetic factors as well. But nevertheless, the studies overall of fitness did show that low fitness is indeed a risk factor for coronary heart disease. So in the decades after the early studies, the landmark studies of Morris and Paffenbarger, prospective epidemiological studies and subsequently meta-analyses have consistently shown that a high level of physical activity, including active transport, cycling and walking, is associated with a lower risk of both heart disease and overall cardiovascular disease. And the data on total mortality actually strongly suggests that the greatest public health benefit probably comes from if you could get the least active people in a population to be just a bit more active. That might be the best benefit in overall population terms. And so walking is an obvious starting point there. And it's sociable, isn't it? It's a low risk of injury, and it's injury that causes a lot of people to cease an exercise habit, and it doesn't require any special skills. So a lot of the studies at Loughborough here in the early 2000s used walking as a mode of exercise. In fact, I should probably say as an aside here that I think Clyde came back from one of the ACSM meetings, the American College of Sports Medicine meeting, and gave me a strong nudge in the direction of using walking as a mode of exercise. We started with intervention studies of brisk walking, and we were able to show that brisk walking is, for most middle-aged people, more than sufficient to cause improvements in endurance fitness and improvements in endurance fitness. It's all this is going on round me. What else was I going to say? Anyway, and modifications to some cardiovascular risk factors. One of my, we did this initially in women and then a study in men with funding from the British Heart Foundation. In fact, my dentist from Loughborough here, he volunteered to take part. He wanted to be in the intervention group, of course, which you can't guarantee. So I breathed a sigh of relief when his name came out in the intervention group. But his receptionist still teased me that he wore out 2 dogs doing my brisk walking study. And with some collaboration from the Department of Human Sciences, we were able to measure as well data on body composition and some information too on changes in calcaneal bone density. And I like to think that some of those measurements provided a platform for Catherine Wood-Wavel's very valuable exercise-specific bone studies. We went on to look at the effect of walking on lipoprotein metabolism in the postprandial state, in other words, after a meal. A key outcome measure for us was the rise in triglyceride concentration, plasma triglyceride concentration, that is, after a test meal. And we used to use this high-fat test meal. It wasn't very palatable. It was mainly cereal and double cream. But anyway, it did the job. And of course, that test, if you like, is a little bit like a sort of fat tolerance test. So it's revealing how the body deals with dietary fat in much the same sort of way as a glucose tolerance test reveals how our bodies deal with dietary carbohydrate. We were able to show that a prior bout of exercise, a prior session of exercise, caused a marked decrease in this plasma triglyceride response to the meal. It was very much attenuated. And that the energy that you expended in the exercise bout seemed to dictate the extent of the drop in the plasma triglycerides. And it was independent of the pattern of the walking as well. So you saw the same drop in triglycerides after either one long bout of walking or a series of short bouts of walking. And we also did a much more of a sort of real life study where we used 3 ordinary normal meals rather than this not very palatable high fat meal, and the effect was still there. The last study in that sort of area, well not the last, but an important study in that area and a difficult one to do, was a detraining study in Loughborough athletes. So we asked them to interrupt their habit of exercise, and it became very clear quickly that the effect of exercise on plasma triglyceride response was an acute effect of exercise. So it's not a long-term adaptation, it's just an effect of each individual session of exercise. And that, of course, reinforces the message that exercise needs to be frequent and regular if you're to maintain this particular health benefit. Finally, just a few comments about walking studies in an entirely different arena. Mike Morgan, who was a good friend, but also a respiratory physician at Glenfield Hospital, he had the insight, the vision, to start rehabilitation for patients with chronic obstructive pulmonary disease. Until that time, really, the cardiac rehabilitation had been the main focus of that sort of work. Anyway, so Mike and I set out to devise a shuttle walking test to measure functional capacity in that patient group. And again, it was based on Clyde's shuttle running test, which of course is so widely used now. And Sally Singh is now Professor of pulmonary and cardiac rehabilitation at Leicester, and she was able to demonstrate that the reproducibility of the test, and its sensitivity to changes in physical activity level in these patients. I would like to argue that in a tiny way, walking studies at Loughborough have done a little bit to provide underpinning for Jerry Morris's very pithy comment, which is that walking is today's best buy in public health.
Thank you very much, Adrianne. I'm going to hand over now to Professor David Stensel, who's going to be talking about the current work. Thank you, David.
Thank you, Stacy, and thank you, Adrianne. My job, I think, is to get you from where we were with Adrianne's work through to the future with Jason. So I got just 25 years to deal with. But a few links with the work that Adrianne was just talking about. She mentioned the detraining study. It's lovely to have Sarah Hurd with us today, who did that work. And Keith Frayne sitting next to Sarah. Your book on metabolic regulation, Keith, was used on our courses for many years. So it's a privilege to have both of you with us. You also mentioned Jerry Morris, and it's really nice for me to tell the story. Jerry Morris was my external examiner, but it wasn't so nice at the time. But nice thing to say. So I didn't really know what to talk about when this came up. A bit like Stuart, very nervous in front of all of you. But I thought, well, what was going on then and now? And these are not definitive, but when I was doing my PhD, it was all about coronary heart disease and risk factors for coronary heart disease. And the discovery before I started my PhD, which incidentally I remembered, it was £3,000 a year, my scholarship. That wouldn't meet the minimum wage, would it? But the discovery by Goldstein and Brown of the LDL receptors, and if you were unlucky enough to have one parent who had a genetic disease that meant they didn't produce these receptors, you couldn't internalize cholesterol. So you've got high cholesterol in the bloodstream. And if you were very unlucky and you had two parents like that, 1 in a million people, you produced no LDL receptors and had extremely high cholesterol. So this was familial hypercholesterolemia. So that was a notable discovery around that time. Why do I mention that? Because that made us question, well, what's the role of exercise in the advent of statins, for example, which lower cholesterol very effectively. And so there was, amongst exercise physiologists, there was that ongoing discussion. And where are we now? We're GLP-1 agonists and very effective for weight loss with obesity. And again, you're seeing in the literature discussions about, so what is the role of exercise in the advent of GLP-1 agonists? And there almost certainly, or there is certainly a role for that. But so these two discoveries then are now around medications are having influence on how we think about exercise. I think Adrianne mentioned or alluded to the debate between physical activity and exercise, and the guidelines about exercise for health developed largely by the American College of Sports Medicine, and such bodies talked about you had to do a certain intensity for a certain amount of time 3 times a week, to the recognition that actually no general physical activity, even in very short bouts, so work started by Adrianne and Sarah and developed by Masashi Miyashita, who's arrived yesterday from Waseda University. Lovely to have you with us, Masashi, showing that just 10 3-minute bouts of walking in a day would lower the triglyceride that Adrianne mentioned, but also blood pressure by about 10 millimeters of mercury, an acute effect. So this is an acute effect of exercise. And we see that for insulin sensitivity and so on and so forth. So there was this appreciation of the acute effect of even incidental type activity. Where are we now? Well, people like Stuart, for example, have been pioneering in showing us that it's not just about physical activity and exercise. It's also about what you're all doing now, because I'm standing, but sedentary behaviour, sitting down, and the amount of time spent sedentary. And Stuart was one of the pioneers that showed how important that is. And then I've put versus the sub 2-hour marathon, which obviously happened a few weeks ago, and the impact that's had marathon running and ultra marathon running, where we've also learned, and we all love to talk about the benefits of exercise and absolutely believe in them, but we've learned more also about the potential downsides. And with ultra marathon running and marathon running, it's almost certain now that there's an elevated risk of atrial fibrillation, common heart rhythm disorder that can lead to stroke. And if you're a mammal, middle-aged man in lycra, that's something to be aware of. We relied a lot on epidemiology then, a wonderful epidemiology, but that we didn't have randomized controlled trials with hard endpoints. What do I mean with a hard endpoint? Rather than a risk factor, like cholesterol, for example, a hard endpoint is having a heart attack. Well, we don't have those RCTs, but we do have RCTs now, the Finnish Diabetes Prevention Program, the US Diabetes Prevention Program, where people are randomized to lifestyle intervention or control, followed up for years, and showing that actually, yes, if you follow the lifestyle intervention, fewer of those people go on to develop type 2 diabetes. So it does work. There were some wonderful autopsy studies back then. I think about the studies showing that people in the Korean and Vietnam War, the soldiers that died at the average age of their early 20s, already had evidence of coronary lesions and cardiovascular disease. So we now know it's a disease that develops early in life, even autopsy studies on children killed in accidents, for example. So we know there's this, that it has its origins early in life, and the quicker we intervene, the better. We have the study of Clarence DeMar, Mr. Marathon, who ran over 100 marathons in his life, and an autopsy of his body showed his coronary arteries were 2 to 3 times the normal diameter. But of course, we don't know whether that was the training or genetic predisposition or both. And we had nice studies in monkeys fed atherogenic diets showing that if they exercised, their coronary arteries stayed wide. And things have we don't have so many of those type of studies now, but with the accelerometry and the MRI and doubly labeled water techniques, things have developed on. So the accelerometry has allowed us to make to move on from questionnaire type assessments of physical activity. One notable study where James Levine put accelerometers into the underpants of 10 men who were lean and 10 men who had overweight or obesity, and measured them every half a second over 10 days. 25 million measurements per person, and showed that people with obesity spent 2 hours more sitting or lying down, and people who were lean spent 2 hours more moving around. But of course, doesn't answer the chicken and egg question. And some of the MRI studies, so a wonderful study with walking, showing that people in their 60s who walk, a 1-year intervention, at the end of the intervention, had a larger left and right hippocampus, higher BDN, brain-derived neurotropic factor, and that correlated with the improved cognitive function risk factor, obviously for dementia. So we've got these wonderful studies now showing the benefits with randomized controlled trials. We relied largely on narrative reviews then, although systematic reviews were coming in, but now much more objective systematic reviews and umbrella reviews. I think you published some of those where you review all the systematic reviews. We have risk factor studies back then, and Jerry Morris's, now we've got precision medicine and genetic risk scores, and those show time. I'm on time and I haven't even got to my second slide. We had the focus on lipids, glucose, blood clotting. We've learned a lot more about work like Letty's on, I've put CRP, discovered in 1930, I think, but on inflammation and inflammatory risk factors. Ghrelin, the hunger hormone, discovered in 1999. Coronary artery calcium and the gut microbiome, all applied to exercise studies. So I will just have to quickly run through then. I wanted to talk about Loughborough, developments at Loughborough. So I think, Adrianne, your grant was the first BHF grant here, first competitive grant in the school. That funded my work and Catherine's work, led on to the BHF Centre, and I think we've got Sonia here today. We have the BHF Physical Activity and Health Centre. And then in 2012 to 17, we partnered with Leicester to look at what training regimes do for athletes and how we can apply that to medicine. And we had the Biomedical Research Centre or Research Unit. NCSEM opened in 2014. The Biomedical Research Centre then, again in partnership with Leicester, in 2017, £11 million, and in 2022 renewed for 26 million. Not most of that went to Leicester, not Loughborough, but a size of it a portion of it came to Loughborough. And then Amanda Daly coming here from Birmingham and launching the Clemes Centre for Lifestyle Medicine and Behaviour Centre in 2019. And the Wellcome Trust DTP, this is a doctoral training partnership which funds allied health professionals to come here and do PhDs. And we currently have a midwife, a physiotherapist, a GP, probably earning more, they're on full salary, probably earning more than me, and a nurse doing their PhDs here with us. And to link back to Adrianne, the person leading that, the director, is Professor Sally Singh, again, Adrianne, one of your first PhD students. So I haven't got to, well, the last thing I should mention then is that the other thing that's changed is the drive for impact. And right at the bottom of my list there is the SHIFT study, the Structured Health Intervention for Truckers. And that's work led by Stacy Clemes, which is looking at an occupation where there's a very high prevalence of chronic disease. And Stacy's work, starting with DHL and moving on now to Transport for London and interest with the Department of Transport, is actually impacting by moving the work that we've been doing here, started by Adrianne and others, into the real world and making a difference. So I'm sorry I've run over, but that's my view.
Thank you very much.
This sounds very useful. It sounds like 10.
Thank you, David. And I'm going to pass over to Jason. Thank you.
Thank you. You've got a 90-minute lunch. It doesn't take you 90 minutes to eat lunch, so we're fine. Okay. Here we go. So this is Isaac Newton quote, standing on the shoulders of giants. So we are standing on the shoulders of giants. And Martin last night gave a really nice talk over dinner And he mentioned that Clyde Williams taught him how to be a scientist. And Adrianne Hardman taught me how to be a scientist. So thank you, Adrianne, for everything. Now, because of the work that Adrianne and David have talked about, to a first approximation, how much physical activity you need to do to solve the problem. Right? We know how much. This is a meta-analysis by Melody Link from Australia, 160,000 people. Basically, if you do 6, 7, 8,000 steps, you're sorted. That's fine. Lift heavy stuff a couple of times a week, that's done. There are some nuances, but that's basically a sorted problem. We have a problem we haven't sorted. This is really, I was just reflecting on this. In this room, like, everybody loves sport, everyone loves exercise, and you are completely atypical of the average person in the world, right? If we do interventions to try and get people to be more active, we can do it for a while. So this is data from the Look Ahead study, so you might not have heard of it. At the time, it was the most expensive ever randomized controlled trial. $250 million. It cost 200. So you had 2,500 and something adults with type 2 diabetes in the intervention group. We've got lifestyle intervention, but same number in the control group, followed them up for 10 years. So you've got the control in red and the intervention group in blue. So top left is weight change, top right is fitness change, got waist and glycemic control. So what you're seeing in the intervention group is you're losing a huge amount of weight. You're increasing your fitness hugely in the first year, and then it all goes away. Okay, so we've solved the first 100 days. So all these plans you see on the internet, get your fitness, that's solved. That's not a problem. What we haven't solved is the first 10,000 days problem. And I think that's the problem that's facing us. And I know there's lots of younger people in the audience. That is the problem to solve. We do not need to solve how much physical activity we need to do. We need to solve the problem is how do we get people to remain active. Okay. So I don't know if you've heard of William Morris. So he is an arts and crafts designer from the, I can't remember what centre, I should have looked this up. He said, have nothing in your houses which you do not know to be useful or believe to be beautiful. And I think that's how we should think about physical activity. We should do physical activity that is useful. So things like active commuting and walking that Adrianne talked about. Or we do physical activity that's beautiful. Physical activity that you love doing, that you're not doing for health. Health is just a byproduct, it's the 10th reason down the line. And I'm going to give you a couple of examples of work that we have done where we're trying to make physical activity either useful or beautiful. Beautiful, okay? So we've done a lot of work with football. Now, what you find is there's lots of men in the audience, lots of men of a certain age in the audience. Men do not listen to healthcare professionals, right? They are a hard-to-reach group for lifestyle intervention. If a GP or whatever tells a woman that she might need to change something, she might listen. The man will not listen, right? So what we've done in a series of studies over more than a decade is engage with the fact that many men have a very strong affinity with a professional football club they support. So what we did is we leveraged that and we looked at top-level clubs you've heard of, like Arsenal and Manchester City and Benfica and Porto and Sporting and PSV Eindhoven, right? 15 clubs, and I'm saying Glenn's here. And what we did is we trained the club coaches to deliver the intervention. We didn't go near them, right? So they delivered in the coach, and the men loved it. And we did a large trial on 1,100 people, they lost some weight. They're more physically active, just what it said in the tin. But we did that by trying to make it something they wanted to do and not make it like eating your vegetables. The other thing that we've done is say, can you make physical activity useful? So if you go to the Netherlands, go to Amsterdam, everyone's riding a bike, right? They're not riding a bike to get exercise. They're riding a bike just because it's the easiest way to get from A to B, and they get their physical activity and a health benefit as a side effect. And there's been some modelling done to say the life expectancy in the Netherlands is 0.6 years higher for the whole population because they cycle. So one of the things that we did was a program called Cycle Nation. So this started off with a paper we published in the BMJ using data from UK Biobanks. This is one of these big epidemiological cohorts, which showed that people who cycle to work had about a 40% lower risk of mortality and risk of incident cardiovascular disease and cancer compared to people who went to work by non-active means. This was taken up in the press. It did very well. We had to go and spoke in Parliament and stuff about it. And British Cycling got in touch, and they said, "Can we publicise this?" And I said, "No. We don't want to publicise it. What we need is we know this work. We know this is important. How do we get people to do it?" So I managed to convince them to give me several £100,000 to do a study to try and develop a lifestyle cycling intervention amongst HSBC staff. HSBC were the sponsor of British Cycling at the time, so we developed an intervention to try and get HSBC staff cycling work. They cycled 3 times a week more. We then did pilot programs in South Asian women in Manchester. The women wearing hijabs. See, the women who would not cycle, they never cycled. They cycled 3 times a week. Well, we've done a pilot in Glasgow, and we're also doing the largest randomised controlled trial of long-term cycling at the moment, which is ongoing, where we're looking at whether we can keep some people cycling at 1 year. And now we're going to do an implementation study. We're in Edinburgh, where we're getting a toolbox to try and see whether we can do it in other circumstances. But I'm going to make a couple of examples around what we did in Cycle Nation. The first is, if someone doesn't engage in a behaviour, there's more than one reason. And there's more than one reason. And so if you do an intervention which addresses one reason, you've got locks in the doors that are not open. So you need to unlock all the reasons why so people might not cycle because there's nowhere safe to cycle, because they don't have a bike, because they don't have skills, they can't do the planning. You need to do all of these things together. So our intervention had 31 different components. So it's a multi-level intervention doing many things at the same time. And the key thing with this is I know how to do virtually 0 of that, right? And Adrianne, I remember once said we had done something, and she said sometimes you don't need to know how to do something, you need to know a man who can. And I think collaboration is hugely important. The problems that are facing us are too big for any one person to solve. So you have to work with others, cross disciplines, cross sectors, cross fields to solve these big problems. And this is an example of it. The second thing that I want to mention is this is an example of a translational pipeline. We observed something in epidemiology, we developed an intervention, we did pilot testing, we did a large RCT, and now we are implementing this in the real world and trying to think about when we're doing our interventions, actually how do we get them in the real world and change people's lives. Last slide. One of the things that for everyone in the room, being sport and physical activity is part of your identity. It's part of the story you tell about yourselves. And sometimes in interventions, we don't necessarily do that. And we found from the qualitative work around in the football stuff, in football fans and training, Eurofit, is when you speak to people, the people who are successful change the narrative. They change the story they tell about themselves. There's an example of one where there was a man who said at the start, he was sitting in a pub, it was raining outside, there were people running. They said, oh, they're idiots. And then at the end, he goes, at the end of it, that's me, I'm a runner. And I think one of the things that we should do going forward is work with the humanities, work with the arts. They're the people who are good at telling stories and narrative, to try and work out ways to not get people active for a year, but get people active for a decade. And I'm going to just actually I'll do one more. One more. The world has changed, David mentioned this. We now have a very effective drug called GLP-1 that is effective for helping people to lose weight. It's really, really effective. And the role of physical activity is now different from it was maybe 20 years ago. So I'm PI on a very large randomized controlled trial of GLP-1 drugs. We're going to test 5,000 people over 6 years. Physical activity does play a role. It plays a role in maintain muscle mass and behavior change. It is important, but it's a different role from maybe it was in 1990. And I think we have to be careful not to be the generals before the First World War that said the thing that we need to do is work out a better way to get hay to horses when the tanks were coming in. The world has changed, and I think we have to go with the world that's changed, and physical activity will play a huge role going forward, but we've got other tools in our arsenal that we can use alongside it. And I think I'll leave it there, so thank you very much.